An original.
From Story Studio Network.
I'm Tom Hoppe, and I'm your host of the Most Painful Podcast. On our last show, we spoke to Dr. Sarah Vadabancourt about supplements for muscle growth. She spoke about the importance of maintaining muscle mass, especially when we age, as muscle loss does not only impact our strength, but also our metabolic health. She also talked about some supplements to help maintain muscle mass. Lots of great information, and if you missed this episode, you can listen to it on our Spotify and Apple feed and receive notifications for the most up-to-date episodes. Subscribe to our show. So many of you may have heard the biopsychosocial model of chronic pain, which means chronic pain is not just physical, but also includes psychological. Today I'm joined by Dr. Tim Salomons, who is a professor at Queen's University at the Department of Psychology, to talk to us about mindfulness, ketamine, and the challenges of treating PTSD. Tim, welcome to the show.
Great to be here. Thanks, Tom.
So, that's a long title. I'm very interested now in this subject. So,
yeah,
maybe, and hopefully I did the intro correct. I know that
absolutely.
A lot of people that I've spoken to contribute chronic pain to just a physical thing, but it is actually a psychological component.
Very much so. And the what we call the physical and the psychological elements very much interact. And, in a way that is why we end up with this issue of trying to treat PTSD and chronic pain together, because they absolutely influence each other.
So mindfulness, we've had Dr. Gupta on the show in season 2 talking about just overall mindfulness, and we haven't had anybody talk about ketamine, but you've brought the two together, mindfulness and ketamine. Maybe you can tell us why.
Yeah, absolutely. So the issue that a lot of, we're working with veterans on this project, and, being a veteran, being in the military involves a lot of both physical and psychological challenges. It's very, it can be very hard. People find themselves in both physical and emotional distress very often. And so this is a population that, as I'm sure you know, sustains a lot of injuries, both psychological and physical. And so we often see, people, veterans of military service, having chronic pain. Up to 50% of veterans have been found to have chronic pain. And of those who seek treatment for chronic pain, one study has suggested up to 50% of them might have post-traumatic stress disorder. Now, the issue that comes up, both of those are very difficult disorders. They're very resistant to treatment. They cause a really great burden on individuals' lives. And the sort of difficult thing about that comorbidity is the two feed off of each other. So if you have chronic pain, it makes your PTSD worse, and vice versa. And they often refer to what they call mutual maintenance factors. So, factors of one disorder that makes the other one more difficult to treat. And one of those might be avoidance, for example. So chronic pain, a lot of individuals, let's say if they have low back pain, it's hard for them to leave their couch. It's hard for them to get up and do things because every time they stand up, they feel pain. So they don't go out. They don't, go out and meet people. They don't, and PTSD also has a lot of avoidance. People are, they're fearful if they've been in a combat zone where crowds are dangerous. They're afraid to go to the mall. They're afraid to go shopping. They're afraid to leave their house. And so, you can imagine that if you've got both of these factors going, they sort of feed off each other. And, so because of this, because the two disorders kind of make each other worse, we really see a necessity to treat them together because they're so frequently, especially in veterans, they're so frequently comorbid. And if one of them is making the other worse and they are sort of in a negative cycle, we sort of see it that we need to treat the two together. Now, unfortunately, there is not a lot of treatments that are designed to treat both of them. And so, that's really our starting point is, I'm also a clinician. I'm a clinical psychologist. And when I was working in our local chronic pain clinic, we saw a lot of people who would come in with chronic pain, but also had post-traumatic stress. And this would make it really difficult for them. It was hard for them to show up for appointments because of many of the factors I've mentioned. And so, we really, but we're not, we're a pain clinic. We're not a trauma clinic. And so we're not, our treatments target pain. And so we really saw a clinical need to treat these disorders together and to, to come up with something that could acknowledge the influence that they have on each other.
I mean, that makes perfect sense when you talk about the avoidance, both for chronic pain and also for mental health coming together. And we see that a lot. I mean, the research that I'm involved in with, we look at identity and mindset and the impacts it has on chronic pain. I mean, that we see a lot of that. What's my purpose? How do I get going? How do I do things? And so when veterans become isolated, I get that. And not just veterans, but I mean, even with civilians who have a psychological
absolutely
concern also have that.
Well, and you've mentioned another way that the two factors could influence each other is that both of them involve sort of a change in meaning and identity, right? Is that, let's say you used to be a very physically, as most of our veterans and many of our civilians, they consider themselves very active, robust people. And suddenly you've got chronic pain and you're not an active, robust person. And, you PTSD also makes you, somebody who needs help and assistance. And this, for a lot of people, especially veterans who have prided themselves on being, robust physically and really in charge of their own destiny, that is a very difficult transition. And, when you put the two of them together, I would say more than double the effect. So absolutely, the two work. And so, this is why we are looking at psychotherapies. We say, this person is avoidant and we need to try to change their thinking, change some of their behavioral habits, get them, maybe not avoiding, maybe help them with meaning, help them, all of these factors we've been mentioning. Psychotherapy is great for that. And psychotherapy is effective for each disorder. But there are very few psychotherapies that are developed to treat both of them at once. And furthermore, I would say that very often post-traumatic stress disorder makes it difficult for people to participate in therapy. So, for example, if we have a group therapy, that can be very difficult for them. It can, it can affect the level of treatment adherence they have and so on. So when we were designing, when we had this clinical problem in front of us, that was, how do we treat these disorders together? Immediately we were drawn to psychotherapy, but also cognizant of the inherent issues, in treating this population with it. So what we set out to do was develop a treatment that is sort of idealized for both disorders. A lot of PTSD treatments are what we call exposure-based, so you are trying to talk people through their trauma in a very calm manner, in a way that's safe for them. And that they're very effective treatments, but, they're not designed for pain. And so we thought, okay, one treatment that actually has been effective for both pain and PTSD is mindfulness-based cognitive therapy. And so that's been kind of our starting point from that angle. And for those of your, listeners who are not familiar with mindfulness, it's basically a practice based on Buddhism, but not, it's not religious in any way as we teach it or as most practitioners teach it these days. And basically you're trying to get people to focus in the present moment in a non-judgmental manner. That is, to just accept what is around them, what is going on right now, without all of these thoughts we often put on ourselves. We say, I'm having a hard time focusing. I'm thinking of all these things. I must be doing it wrong. I'm bad at this. I'm failing. We want people not to have those. We want to train them to, when we're teaching mindfulness, we want to train them to sit and, sometimes a distracting thought comes in your head. Sometimes you feel anxious, you feel whatever. We don't want them to get caught up in that whole cycle of judgment. We want them just to, over time, learn to sit with sometimes difficult emotions, sit with what they feel in the present moment without all of the judgment. So it's a very useful practice for a wide variety of mental health concerns. And also, a lot of people who don't have mental health concerns find it just a useful way to focus their attention, maybe center themselves, relax a little bit. So, because it's been used for both chronic pain and PTSD, we thought this is a great starting point. So, the starting point has been, we're going to develop a protocol that mindfulness-based protocol that will treat both pain and PTSD as as a comorbid entity, and maybe address some of these mutual maintenance factors.
Yeah, because that's interesting. Because I think mindfulness is important. I've tried to do it myself. I would suggest many veterans have a hard time sitting.
Yeah.
So maybe it's more movement-based mindfulness, which is more helpful.
And that's the nice thing. A lot of people think of it as sitting, in lotus position and breathing deeply, but you can do a, walking mindfulness. You can do a, eating mindfulness, like
fishing
it's really
mindfulness. Yeah,
very much so. I told my wife I was doing a sports mindfulness on Sunday, but that was a bit of a fib. But
that didn't work, eh?
No, not so much.
So, this is a research, and we kind of talked offline a bit, but this is a research that you're starting to find that connection. Mm-hmm. How does that lead into, ketamine has been used for chronic pain for some time.
Yeah.
And also, if I understand it correctly, also been used for PTSD.
Yes. So, basically, when we started down this road of, what's a psychotherapy that could treat both of these, you run into some of the inherent issues, of psychotherapies. Psychotherapies are effective, but they don't always work for everybody. And we're really hoping, what can we add to a psychotherapy that will make it more effective? And one of the problems is that, PTSD involves almost a locking in of really strong beliefs and cognitions and fear memories and avoidance behaviors and so on. And you feel like we almost need, to get people to the point where they can benefit from a psychotherapy and really hear what you're telling them and, learn new habits that will sort of overwrite these sort of post-traumatic thoughts and habits. It sometimes almost feels like we need an icebreaker. We need something to break through and sort of almost the way you do a computer reset, okay, my computer's moving really slowly. I'm just going to reboot it. And then, it will help. And when we were thinking that way, ketamine is something, as you mentioned, it has been used to treat pain. It has analgesic properties. But it also has some really interesting properties in terms of changing thoughts and behaviors. It's what they call an NMDA receptor antagonist. And, I don't expect all of your listeners to know exactly what that means, but essentially an NMDA receptor is one of the things involved in what we call neuroplasticity. And we often talk about neuroplasticity, which is sort of the changing of brain structure by behavior, adaptive changes in brain structure. But we often talk about adaptive changes, like neuroplasticity has helped me overcome this brain injury, etc. But there is also negative neuroplasticity. With PTSD, we often get a kind of neuroplasticity that burns in kind of fearful memories and avoidance behaviors and so on. And what we and others believe, and based on the existing science, is that ketamine might be something that helps just kind of break up some of those harmful associations. And what we've found from the animal literature is that it disrupts fear memories. It can help change avoidance behaviors. There have been some preliminary trials using low-dose ketamine to treat PTSD that have shown a lot of promise because of those things. So, because it's both an analgesic and potentially a drug that can break up those maladaptive cognitions and behaviors, we thought that may be just the thing to help facilitate the effects of psychotherapy. And so we're not the first to think of this idea, but ketamine-assisted psychotherapy has been, in trial in many different contexts to treat depression, to treat some anxiety disorders. There have been a couple of trials of PTSD that have shown promise. There's been one trial that has used it for comorbid pain and PTSD, but in that trial, they did a 5-day continuous infusion.
5 days.
5 days. I don't know many people who can spare 5 days and are, you mentioned that, a lot of veterans and people with PTSD have a hard time sitting down. Well, we're asking them to sit down for 5 days for an infusion. And so we thought, that is great. It shows promise, but we need something that people who have jobs and maybe who don't want to sit in a hospital for 5 days or really feel like they can't sit in a hospital for 5 days can do. And, the hospitals are also under-resourced. So, it's very hard to say, hey, here's a patient, you're going to, put them on an infusion pump for 5 days and let's hope it works, So we saw that as really not a very plausible way to treat the problem. So we're hoping that we can do a more user-friendly, lower dose version of the same thing.
Yeah, in 5 days, one's got to wonder what kind of impact that has on the body too.
Yeah.
What are the side effects of that, right?
Right. And so we also, as you probably know, ketamine is an agent that can be used, recreationally and abused recreationally. And, so a lot of people, when they hear about this, they think, oh, that sounds kind of dangerous and concerning. But the doses we're using are very low, so we don't expect any, we're not there's a lot of psychedelic research these days where people try to use heavy sort of psychedelic states. That's not in this study what we're aiming for. What we're hoping to do is in the individuals who are randomized into the ketamine-assisted psychotherapy group, in the first 2 weeks of the mindfulness protocol is about 8 weeks long. So right. It will be an online intervention that will take about 2 hours of each week in terms of the individual's time. But then for the first 2 weeks, we're going to have them come in twice for 1 hour long ketamine infusions. And they're very low dose. They will be monitored very carefully, but they're very low dose. We don't expect any kind of, we don't expect people to feel high or to walk away in a daze. We're hoping that it's very, as I said, user-friendly and, but that in the preliminary trials, it seems that that's enough of a dose that we get some of those effects of just, I use the metaphor of an icebreaker. We can just break up the ice and, maybe that will facilitate the effects of the psychotherapy.
And like you said, it's been done before. And you also mentioned that, usually these things are done in isolation, even in an interdisciplinary pain clinic where you have all the services. It's still pain is done over here, allied health or physio is done here, and then you do your psycho. So what you're doing is you're bringing that together. You're bringing the pain relief and the psychology together then.
Yeah,
basically.
Very much so. Well, and, I think that's important because, psychotherapy obviously has biological effects. Anything we do, any behavior has a biological effect. So it's not like, this isn't sort of a dualist notion that there are psychological things and biological things. But psychotherapy doesn't necessarily directly target some of the biological factors that kind of are behind these behaviors and these thoughts. And so, our thinking is that with the combination of the psychotherapy and the biology that we get the best effect. Because the downside of a drug can be that the patient feels like this isn't me doing this. This is the magic pill that my doctor gave me. And, really you want to give them a sense of ownership. You want them to also have some skills that they control, that, they feel like, okay, if I do venture out to the mall, even though I'm afraid to go, do I have some tricks that I can, do I have some tools that I've learned that can help me make it through that situation. And so I feel like the cycle, it's a very good combination that, we're targeting the biological factors that lock this in, but we're also giving them, hopefully skills that are portable, and that they feel ownership over. This is me. I am capable of, overcoming a situation, and I think that's a really important thing in terms of people feeling, you don't want them to feel like they need their magic clinician or their magic pill. You want them to feel like, I am in control of this situation and I have a toolbox that I can use to get me through this.
Well, 100%. I mean, that's the Military Veteran Alpine Challenge that we started is exactly that, is to provide education and knowledge, to work as a team to help each other, because we know chronic pain can be lonely, but also to provide those tools so that people can understand a military mindset and other things that are impacting. Now, it doesn't replace anything that the pain clinicians are doing or psychologists are doing.
No.
But it's just that component of giving that person some control, like you're saying, versus just relying on a clinician. So when you're doing the ketamine infusion, is there talk therapy going on at that time too, or is it
No, so this one is a little different. So that is one way that this kind of thing happens, is that, one way they do this is that they, they'll give that's usually associated with a heavier dose, that they will give a fairly heavy dose and do talk therapy to kind of talk people through the experience. Usually that's when you are trying a more psychedelic approach, that you are, taking advantage of some of the, maybe the high, so to speak.
Right.
The therapy will be actually separate from the session, and that, some of the preliminary research suggests that actually works well. And, I think it, in a way it's nicer, because then we can sort of leave the drug infusion for the physicians who, we have a local ketamine clinic here in Kingston that, is very experienced with doing this kind of work. We can leave that to them, and then our therapy just goes on as normal. So it's the nice thing is that it's a minimal disruption to the way the hospitals normally work. So, and hopefully it's minimally disruptive for the patient as well.
Yeah. I mean, it sounds interesting, and I'll be looking forward to what you guys, the results that come out of this, and have you back on to talk about it. Because, as this is not just for veterans, this is anybody who's struggling with pain and PTSD. This is going to be helpful for everybody.
Yeah, absolutely. And, we as a clinic, our chronic pain clinic is really ramping up our outreach to veterans. But as you say, anything we find here, we can apply in general to the population, because, there are a lot of people out there who are suffering with PTSD who don't, and, because of the siloing of the healthcare system, we're a pain clinic, and often we have to send, if we see PTSD prominent in people's symptoms, we have to send them to another clinic. Well, by the time they get there, how long the wait lists can be and everything. So, if we can take those people, if this is effective and we don't have to send those people to another clinic, I think everybody benefits.
Yeah. Coordination of care is important.
Absolutely.
It helps speed things up, and, nothing gets lost. So, Tim, I appreciate you being on the show. It was a good learning.
Yeah, it was my pleasure. And I'm happy to come back when we have some results.
Yeah, well, I'm looking forward to it. And for our audience, for feedback about the show or more information on chronic pain, you can visit us at our website, veteranschronicpain.ca, or follow us on Facebook and X on Chronic Pain COE, and on Instagram at chronicpain_COE. Everybody stay safe and keep the hope alive.
The Most Painful Podcast is produced for the Chronic Pain Center of Excellence by Story Studio Network.